So for this session, we have two facilitators. Fortunately, Professor Judith Kolobi will not be there. And thank you. So we'll hand over to our facilitator, Professor Makumba Gay. Thank you.
Thank you very much. Consider we can start our session now. I would like to introduce Professor, the presenters of this breast session. We started now for almost 2 hours. So we would like to give the floor. I'm co-sharing this session with Professor Didi Kuku, that we are waiting for. And we would like to start our session and give the opportunity to Dr. Jedi Agba to give his talk about epidemiology and characterization of breast cancer in Africa for 15 minutes. So Dr. Jedi Agba, please take the floor if you are here. It seems that Dr. Jedi Agba is not yet present. So maybe that we can start with Dr. Carla Barbosa of the Central Agostino Neto Hospital, who is sharing the Department of Oncology Disease, so that she will give a talk about pathology of breast cancer, status of breast cancer genetic testing in Africa. Dr. Carla Barbosa, please take the floor now if you are ready. That also Dr. Carla Barbosa is not yet ready to go. So Dr. Obajimi also, so we will change the schedule and start with Dr. Anna Simon, who is the head of the Clinical and Radiation Oncology Division of Stellenbosch University. Her main clinical and research interest is in the implementation and modification of international treatment guidelines in a low-resource setting, very important issue for all African countries. Professor Anna Simon, please take the floor and start your talk, please. So Professor Anna Simon, please, should you please start your...
Thanks, will do. I'm just going to find my screen. Sorry, I wasn't quite prepared for you.
Well, you have the floor. We will have...
Sorry, give me 2 seconds and I should be with you. Good. I hope you can see my screen. So my topic this afternoon is to discuss how in resource-constrained environments, what are the best buys in systemic therapy for early breast cancer? So just as an introduction, I'm going to discuss what is available and to discuss what I feel is cost-effectiveness in a theory of cost-effectiveness in Africa, what drugs are cost-effective, and what strategies do we have for access. So what's available? Well, we have hormonal therapies in most countries. We can get tamoxifen. AIs are available in more of the middle-income countries, anastrozole, letrozole, exemestane, and even in 1 or 2 countries, we can get fulvestrant. And chemotherapy, almost every country should have access to anthracycline. And in most countries nowadays, because of generics, we have 3rd-generation taxanes available, usually Taxol, which is the cheaper one. And targeted therapy is available as a buy-in in many countries and is available in the state sector in South Africa to some patients. So I just want to explain a little bit of health economics, and the disclaimer here is that this is explained by a clinician. So what is cost effectiveness? Well, it's clinical outcome and the cost of that outcome. And it's calculated using an ISA, which is the incremental cost effectiveness ratio. And usually it's based on a country's gross domestic product. And something is usually declared cost effective between 1 to 3 times the GDP, which is the WHO definition, per patient life year gained. And in oncology, we normally talk about QALYs. In reality, an ISA is usually 1 times the GDP because many of us can't afford it. An example in the breast cancer setting is 1 year of trastuzumab in Colombia works out at cost effectiveness of US dollars of $71,000 per quality of life year gained. But the GDP in Colombia is 15,000 US. So trastuzumab in Colombia is 4 0.7 times the GDP per QALY. So it's not a cost-effective drug in their setting. What should we aim for drug availability in Africa? Well, or drugs in Africa, we want availability, we want affordability, we want quality, good quality drugs, we want equitable access for all, and we also want rational use. And what information do we have about cost effectiveness in Africa? Well, I'll tell you, we do not have enough, and we desperately need even more clinical studies in Africa because we don't have outcomes. And we need more economic studies that capture all the costs for a patient. So it isn't just about drug costs when you talk about cost effectiveness, because you need to take into account side effects, cost to the patient of travel, loss of income, transport costs, etc., etc. One study done by colleagues was a meta-analysis to try to look for studies in low middle income countries. And after screening more than 6,000 papers, they came across in total 91 papers that were suitable for review. So on the individual drugs, well, hormonal therapy, what is available? Tamoxifen, yes, it's pretty cheap, but what about unwanted side effects and complications of using these? And there are only 2 developing country studies looking at cost effectiveness, which showed that AIs are more cost effective than tamoxifen due to reduced complications and improved clinical effect. Additional hormonal therapies such as goserelin, there is one study from China which showed it was more cost effective to use goserelin in early breast cancer patients than docetaxel due to complications and cost. So this is not a definitive outcome, but it should not be overlooked in a setting where chemotherapy drugs are perhaps expensive or unavailable. And also the secondary indication for adjuvant goserelin in high-risk young women for ovarian suppression, again, is something to consider because it may prevent complications further down the line. So chemotherapy, well, we have no information in Africa on outcomes really of anthracyclines versus taxanes alone or versus anthracycline taxane complications. And we have some data, but all of it is retrospective, and again, not a lot available of what the impact of HIV is on toxicity in chemotherapy patients. But intuitively we know that anthracyclines lead to cardiac toxicity, which is an expensive complication, and taxanes lead to neutropenia, which is obviously a complication leading to prolonged hospitalization and risk for the patient. The only data that's really available that's relevant to our situation is that from the UK, from the NICE, and they reviewed this question to say which people with early or locally advanced breast cancer would benefit from the addition of taxanes with anthracycline-based chemotherapy, and they did a systemic review of the economic literature. Their bottom line was the addition of taxanes were not found to be cost-effective in patients, particularly with HER2-negative disease, with an ISA above the NICE threshold of £20,000 per QALY, which is well above the ISA for most African countries or for all African countries. I think it's very important to make use of online tools to really determine the clinical benefit before you embark on treatment for your patients. And what is important, I feel, in a resource-constrained setting is that overall survival must trump all other outcomes. And an example of an online tool is Predict. And just a quick example of this, a 54-year-old patient who's ER positive, HER2 negative, with 1 positive lymph node. What is the benefit of second-generation chemotherapy for her? 5-year overall survival, a benefit of an additional 1.2%. And if she gets 3rd-generation chemo with taxanes, the 5-year overall survival benefit is 2%. So both interventions, either with an anthracycline-based or anthracycline and taxane, will only improve overall survival for a node-positive woman over the age of 50 who's ER positive by 2%. Is chemotherapy even clinically necessary in this situation, and will definitely not be cost effective? So again, a reminder, what is the real clinical benefit and what length of overall survival or percentage of overall survival is important in your practice? What drugs do you have available and at what cost? And user fees is a major issue for us here on the continent of Africa. National health insurance is not available in many countries, and in some countries will only cover 1 or 2 drugs for a specific disease. So taxane should not be the default. And good old CMF, it's still cheap, it's effective and has a low toxicity and should still be considered when you can get availability. HER2 targeted therapy, now this is a real high cost intervention. There are many, many cost effective studies, and the current recommendations in a lower resource setting such as ours should be 6 months rather than the 1 year in the adjuvant setting. But again, I would encourage people to use online resources to look for the real benefit for overall survival in these patients, which is ER negative, node positive young patients. But there are real barriers to using high-cost agents for us in Africa, and that is availability. Even if you can get it in, you'll pay high import duties. Biosimilars are not yet available across the continent, and trying to save money by getting discounted costs by bulk buying through government healthcare facilities is not available in many, many countries. And I recommend for those of you that are interested in looking at cost effectiveness in sub-Saharan Africa, I refer you to the paper here. And I've just highlighted a couple of issues from that paper. First, what ICERs do we actually have in Africa? So in Congo, taking account the current GDP, an ICER is around about $2,000, similar in Nigeria. In South Africa, a cost-effective drug should cost about $5,000. This particular paper looked at the ICER for every country if they were to start using Herceptin, and it seemed across the board that the ICER for trastuzumab was $20,000. And when we look at a cost-effectiveness ratio of GDP per capita, then for everybody it was at least 4 times the GDP, and in many countries well over that. And this is very well illustrated here on the graph, with the pink being the cost of trastuzumab, being about $20,000, and in the affordability for each country in turn. So an alternative approach to high-cost medicines is universal healthcare. We need national policies on cancer control. We need equitable access in a country and reduced user fees. Central funding is a way to go, but it doesn't always work. An example of this is the UK Cancer Fund for high-cost medicines, which started off in 2010 with a budget of 20 million, but 5 years later had overspent by over 1 billion. So there really must be strict criteria, and we must take cost effectiveness into account and not ignore it. The other thing that we need, which we lack again on the continent, is good, solid medicines control agencies, because we want to avoid the import of poor quality medicines, fake and poor quality generics, because it increases inequity in Africa. The key bottom line is national evidence-based policies that grades and prioritizes interventions that are cost effective. So just some concluding thoughts from my part. In LMICs, generally, we make do with what we have and what we can afford, but we're really hindered by fragmented healthcare and held back by user fees. And I think it's very important for all of us as a collective and to have a voice within Aortic to strive for justice and try to remove these barriers for care. Thank you very much.
Thank you very much, Professor Anna, for this very important advocacy. And definitely we need to use our success for the fulfillment of lives. So we need to talk again and talk together about all this. And for sure, we will have some questions about this cost effectiveness at the end of the session. I would like now to give the floor to Fatima Cardozo, and it will be a great pleasure for us to let her talk about, the
Triple negative.
of triple negative patients. I'm really sorry for that.
No problem.
Unfortunately, we are waiting for some presenters, and at the end of your talk, maybe that they will be there to go further. Thank you.
Thank you very much. Thank you for the invitation to be here. And I'm just sharing my slides. Please let me know if you can see it.
It's perfect.
Thank you. All right, so it's my job to review with you the management of triple negative breast cancer and try to do this in the next 15 minutes. So I will have to go a little bit fast, but I hope to be able to pass the most important take-home messages. So these are my disclosures. And I divided my talk in 3 main parts. So one is about definition and biomarkers that are really important for triple negative management, and then early triple negative disease and advanced triple negative disease. So regarding definition and biomarkers, the take-home messages are that it is crucial to have high quality pathology for a good definition of what is really a triple negative disease, and to avoid withholding important treatment and inexpensive treatment such as endocrine therapy if in fact it is not a triple negative. We also know that triple negative is a very heterogeneous group of tumors. However, this different subtyping within the triple negative is not yet ready for clinical practice. So the useful biomarkers for clinical practice regarding triple negative is, of course, ER, PR, and HER2 for the definition of triple negative. And then if you have access to the drugs, PD-L1 and germline BRCA mutation status. So we are all aware of this new molecular class, well, not so new anymore, but since the year 2000, the molecular classification of breast cancer with the different subtypes. And you also see that these different subtypes have prognostic value in the graphic below. And the ones that have the worst prognosis are the HER2 enriched when not treated and the basal-like. So this just a small comment regarding the previous talk. Because of cost effectiveness, we also need to look at prognosis. And HER2 positive disease, when not treated, is the most aggressive subtype, right? Followed by the so-called basal-like. Now, we don't use molecular classification in clinical practice because it is so expensive and hard to perform logistically. So we use surrogates. And for this, what triple negative is concerned, we use it as a surrogacy for basal-like. So we consider ER/PR HER2 negative. And this is comprises more or less 15% of all breast cancers. There is still an ongoing controversy if the cutoff for negativity is below 1 or below 10% for ER and PR. Also, another important note is that everything we're going to discuss is about ductal or non-special type triple negative. But there are many rare histological subtypes that also have this phenotypic of ER, PR, and HER2 negative. However, they do not behave the same way. So these are all different histological subtypes showing that the pathology works. So the way we look at the microscope and the morphology is still very important to classify a tumor. Some of these have good prognosis, some of these have bad prognosis, but they are not the ones we are talking about when we say basal or when we are issuing recommendations on how to treat triple negative disease. Just one additional point regarding the quality of pathology. So this is a study done in Canada. And what it shows is quite frightening. It showed that the percentage of ER negativity and PR negativity would vary according to the day of the week. So why on earth would it vary according to the day of the week? And then they made some evaluations and saw that on Fridays, the tumor piece was left without being processed until Monday. And that has led, of course, to a degradation of the proteins. So this is just a reminder. There are many factors that influence the quality of a biomarker. And we clinicians take all our decisions based on pathology. So one of the fundamental fights for fighting inequalities is not just expensive medicines, but fight for high quality pathology so that we can make a proper diagnosis, a proper classification of the tumor, whatever it is, whatever type of cancer, and then take the appropriate therapeutic decisions. And this is why we think that perhaps triple negative breast cancer is not so prevalent prevalent in Africa as we initially thought, and that some of those initially classified as triple negative may actually not be triple negative if we have a better quality of pathology. As mentioned, the triple negative is just a mixed bag of many different subtypes. However, this is still a matter for research, and we don't have any strong recommendation to use these different subtypes to treat differently. So also for advanced disease, these are the biomarkers that we need. Estrogen receptor HER2, if we have access to the drugs. If not, we shouldn't look for the biomarker like PD-L1 or germline BRCA mutation. If we don't have access to the drugs, is a loss of resources to go look for the biomarker. And what is not recommended for breast cancer, be it in low or middle or high income countries, is the multi-gene NGS panels. Now moving to early triple negative breast cancer, what are the take-home messages? So chemotherapy is the mainstay of treatment and should be preferably used as a neoadjuvant approach. This, of course, means that you need to work in a multidisciplinary team because surgery and radiation after neoadjuvant therapy are far more complex and need a multidisciplinary discussion. For the type of treatment, the standard is anthracyclines followed by taxanes. There is some role of platinum for very high-risk tumors, and there's also some role on post-neoadjuvant capecitabine. There are emerging roles of pembrolizumab and olaparib, but they have a major problem, which is the very high cost. So one note about neoadjuvant approach, we have started using neoadjuvant approach first to render a locally advanced inoperable tumor into operable. Then we started using also inoperable but very large tumors. What we know is that neoadjuvant improves local control, improves rate of breast conservation. It doesn't hinder survival. It doesn't improve survival either, but it does not hinder. And since the 2000s, we've been using the neoadjuvant to be able to tailor treatment. For example, the use of new agents in the post-neoadjuvant setting. Now, in terms of type of agents, what we know, most of what we know come from what we call the Oxford overview or EBCTG data. The Early Breast Cancer Trialist Cooperative Group. And we see that adding CMF to nothing, we gain 4% in survival. Adding anthracyclines to CMF, we gain another 4%. Adding taxanes to anthracyclines, we gain another 5%. And all these steps have led to a very important improvement in overall survival. Two other points that I will not detail. We have studies showing us that 5-FU is not needed. It does not improve efficacy and increases toxicity. So don't use any more FEC or FAC, but use either EC or AC that is sufficient and far less toxic. We also know that dose dense, so increasing the interval, improves overall survival. However, you need to use growth factors to do this, and growth factors are substantially expensive. So dose dense comes with a substantial increase in cost. Now, what about the use of platinums? There were a huge number of trials looking at the use of these agents. All of them were quite small. So there was this meta-analysis looking into all these studies. And what it shows is that the use of platinum in the neoadjuvant setting improves PCR, so it improves response rate. But when it comes to overall survival, there's almost no difference. So we need to consider that platinum also increases toxicity. So there is an increase in efficacy, but there is higher toxicity. For example, it has an effect on fertility, and most of these patients are young women. So this needs to be taken into account. So we recommend, and most of the guidelines recommend, reserving the platinum just for very high risk situations, such as locally advanced breast cancer, or cancers who do not have a response to anthracyclines. And if you are using a platinum and it's not being well tolerated, stop and try to administer the taxane, which is far more important, because sometimes when we give it together, the bone marrow does not allow us to continue the chemotherapy. Now, one word about this study, which is an Asian study called CREATE-X, a Japanese mostly study, that has shown that the use of capecitabine in the post-neoadjuvant setting, when we do not achieve a PCR with standard chemotherapy, leads also to an improved overall survival, specifically in the triple negative population. And capecitabine is not a very expensive drug, and it's a good way to improve outcome for these patients. Now I'll go very, very briefly on the two targeted agents, because first, they are not yet approved or available in the majority of cases. And second, they add so much cost that I'm afraid they wouldn't be a possibility for the continent in Africa. So pembrolizumab, which is an immune checkpoint inhibitor, was studied in the early triple negative disease. It led to an improved PCR, but much more important than that, it shows an absolute 7.7% benefit in event-free survival. So this is becoming an option in high-income countries. Another option in high-income countries is for germline BRCA mutation patients who have a triple negative disease or ER positive disease, and that are at very high risk. So there are other characteristics such as node positivity and other characters, tumor size and so forth. And this Olympia trial evaluated the role of a PARP inhibitor, olaparib, in the early setting, and it showed an improvement in invasive disease-free survival, an absolute benefit of 8.8%. Again, the problem is the high cost of this agent. So moving to advanced triple negative disease, the take-home messages are chemotherapy remains the main option or the main treatment option. Single agent and not combination, not even for triple negative. This is an important take-home message. Single agent is recommended. We now have 3 types of targeted therapy for advanced triple negative: checkpoint inhibitors, PARP inhibitors, and an antibody drug conjugate called sacituzumab govitecan. The biggest problem of all these 3 agents, they are very, very costly. And for the first time, we have seen an overall survival benefit for this metastatic setting. So a couple of additional points. Managing advanced triple negative in real life, what happens is that this subtype of breast cancer has the shortest overall survival, with a median overall survival, even in high-income countries, that is below the median of 3 years. So it's around 1.5 to 2 years. Every line of treatment provides you less and less benefit, and very few patients also achieve, for example, beyond 3rd line of treatment. In terms of options, you can see that most of them are chemotherapy options, and only more recently we've been having these 3 types of targeted agents. Now, just a reminder that because advanced or metastatic breast cancer is incurable, we aim at this balance between quantity and quality of life. And so this has to be in our minds in every treatment decision. And that's why I would like to remind you of this Cochrane meta-analysis and of the recommendations of all guidelines. The ABC guidelines, the ASCO guidelines, all the guidelines recommend that you use sequential monochemotherapy and not combination chemotherapy, because there is no improvement in PFS nor improvement in overall survival, and clearly toxicity is much higher with combination chemotherapy. Also, a couple of other take-home messages is choose with your patient the toxicity profile. The efficacy of the different chemotherapy agents is not very different. And so you should discuss what type of toxicity they give and see with the patient what she or he prefers to avoid. Dose reductions are very much acceptable and often needed in the metastatic setting. So don't be afraid to reduce the dose. This is not early disease. Dose intensity is not so important. Oral, whenever you can, please use oral drugs instead of IV. So we have oral capecitabine, we have oral metronomic chemotherapy with cyclophosphamide, methotrexate, very inexpensive and very effective for triple negative as well. And so again, please look at the patient preferences. Now, a few very fast words about the targeted agents. So PARP inhibitors use the principle of synthetic lethality, killing more cancer cells than normal cells. The problem, as I mentioned before, is the cost of these agents. What is the current recommendation? We just finished this weekend the 6th edition of the Advanced Breast Cancer Consensus Conference, and you are the first one seeing the recommendations fresh from the consensus session. So the recommendation for PARP inhibitors in the metastatic setting is that single-agent PARP inhibitor is one of the preferred treatment options for triple-negative metastatic disease, although they have not shown an improvement in overall survival, but they show an improvement in quality of life and a favorable toxicity profile. And we now also have data of their potential use in somatic mutations of BRCA and germline PALB mutation. This is based on 2 studies that use this design, compared single-agent PARP with monochemotherapy. And you see the names of the chemotherapies and the names of the trials. And basically, they've shown about 3 months difference in PFS, but a better quality of life. However, this better quality of life comes at a higher financial cost. And this is so this first one was for olaparib, and this one is for talazoparib, the same results, same thing. Now, the second type of targeted agents is immunotherapy with the checkpoint inhibitors that we all hear a lot about, particularly for other cancers, but we haven't had fantastic results in breast cancer. And we know also that this leads to a very important new spectrum of adverse events that are hard and expensive to treat as well. And also the treatment is expensive. However, in terms of recommendation, of course, if you have access to it, what we now recommend is mostly the use of pembrolizumab with the taxane or with carboplatin gemcitabine as the preferred treatment option for first-line therapy on triple-negative PD-L1 positive tumors. The use of atezolizumab is under controversy since it was withdrawn from the US. It's still available in Europe. It can be an option if you combine with nab-paclitaxel. But nab-paclitaxel is also extremely costly, so this combination becomes very, very difficult to use. So this is the study, KEYNOTE-355. And what you see here for PD-L1 positive using the CPS score, you see a benefit in PFS, and now we are waiting for the benefit in OS that will be presented soon. And in terms of side effects, surprisingly to me, in clinical practice, they were, let's say, acceptable because only about 20% of withdrawals from the treatment because of side effects and no toxic deaths. Last point about the new antibody drug conjugate called sacituzumab govitecan. We have seen an improvement in 5.5 months for overall survival for heavily pretreated patients, more than 2 lines of treatment. And this is not an easy drug. It also has side effects. Nausea, vomiting, is diarrhea. So this is important to make prophylaxis an early intervention, and it is, of course, very expensive. So just to show you what it is, so the antibody functions as a bus and takes the molecules of chemotherapy inside the cell, giving less toxicity than if you would give it systemically. The trial was the ASCENT trial, showing this benefit that you see here in overall survival and also at the cost of side effects. So the the conclusion is that in terms of treatment, because of high costs, chemotherapy is still the mainstay of treatment. However, you can do a lot with the different types of chemotherapy that exist, and you should really pay attention to the side effects of each of the options and discuss that with the patient. Thank you very much for inviting me, and I'm ready to answer any questions.
Thank you so much, Dr. Cardozo, for this very impressive talk on triple negative patient. For people who are joining us, Dr. Fatima Cardozo is the director of the breast unit of the Champalino Clinical Center in Portugal. She is also president of the Advanced Breast Cancer Global Alliance, as well as the founder and chair of the ABC International Consensus Guidelines Conference. Thank you so much for this very, very impressive talk. It seems that 4 of our speakers are missing, so that I think that we can directly move to some questions and answers for the speakers. I would like first to ask to Professor Anna, what is for you the definition of cost effectiveness for very low income countries? Do you think that each country should have its own definition of cost effectiveness, or is it only a global concept? Or should we have some very specific criteria taking into account financial possibilities, the main technical equipment that we have, and so on? What will be your answer about it?
So I think it's useful to use the WHO guideline that says to consider your GDP per quality of life to be somewhere between 1 to 3 times your GDP when you work out your ISA, because not all of us are health economists, and I think that we should pay attention to the work that's been done before. I think realistically, we should work within the realms of 1 times our GDP for most of us in Africa, particularly low-income countries. But then you're right. From then on, once you've taken that as a baseline, within your own environment, you need to have some kind of national cancer plan where you decide what is a priority and what is not. And if you have made a decision that something is a priority and you're prepared to pay above your ISA, then that's right for the country that you're in. So no individual country should follow something that a country has made with their own national policy. All of us are different. All of us have different burdens of disease. It depends on what's important. So for us in South Africa, we have a massive burden of disease of HIV and TB, which means that cancer care, unfortunately, often takes a little bit of a backseat. But I think, yes, individual countries, based on some ready criteria that's laid down by health economics, should work out their own situation that is relevant for their own population and burden of disease.
May I add something? I just wanted to tell you that in terms of medicines, for example, which are a big problem all over the world, not just in low middle income countries, there are some tools. So there is the ESMO magnitude of clinical benefit scale and the ASCO framework of value that try to score the treatments with an objective score, and that may help providing a list of priorities. Because, for example, in Europe, in some of the lower income countries, sometimes we see that drugs that are not very important are reimbursed, and then others that are very important are not. So we can also use these tools to see what is really a priority, and if you have very limited resources, focus exclusively on those that provide the highest benefit. Even those, of course, are sometimes too expensive for the majority of countries.
And what should be the role of cooperation in Africa in terms of industry, pharmaceutical industry? Do you think that the issue is to have some more pharmaceutical industry in Africa, or do you think that it's more a global problem of organization?
So I personally think we should try to solve our own problems in-house in Africa. And actually, I see on the app, somebody said an alternative approach to high-cost medicine is for us to manufacture these drugs in Africa. And I think that's very important, because I think import duties and getting hold of stock can often be an issue. And generic companies that can develop generics in-house in their own regions should do so. And I think that it's important that we have some regional cooperation. So if there is a pharmaceutical company in Tanzania, then maybe they could be the hub then for East Africa to make sure that there is drug supply of even if it's basic tamoxifen or something like that, which will be way cheaper than importing it. So it is important that we try to focus on developing a pharmaceutical industry on the continent for multiple reasons, and that it would help the economy and support the economies in our own countries as well. At all times, we should strive for some self-sufficiency wherever possible.
Thank you so much. And do you think that the quality of generics is also an issue in this field? Because sometimes we talk a lot about generics for Africa, saying that it is cost effective to use this kind of products. And how about quality? How can we assess it? How can we make sure that quality is very well addressed? Is it an issue for?
So I think this is an issue that was discussed in the opening session of Aortic about quality medicines in general in oncology. And I know that there is a lot of push to try to raise this issue at the WHO to support this problem for us, because not many countries have a good solid medicines controls council, because that's what you need to have to make sure that what you import into your country is a quality drug. But the infrastructure for a medicine controls council is obviously quite complex and is not suitable for some of the smaller countries, and particularly the low-income countries. So I do believe, and I support the pressure on the WHO to support us to try to make sure that with this inequity of dropping poor quality generics on Africa stops, because it just makes things worse for us.
Should we move the quality assessment to an international level so that all generics be tested at an international level before being sold in Africa? Or do you think that each country needs to have its own policy?
Or a generics registry at an international level, so that we could actually check the registry to say, okay, we know it comes from this company, we know it's a good drug, and then we're prepared to import it in.
Thank you very much for this very interesting speak and for this contribution to the development of quality and cost effectiveness in using medicine in oncology in Africa. I would like to move to the second presentation and addressing one very important point. This late process of pathology pieces to address the hormonal receptors, and so what is the solution in Africa? Because wherever you go in West Africa, we have the same problem. The late delay of proceeding and the late delay to get results. And sometimes we wait two months to get pathology results, and we need to start treatment. Should we use treatment, treat all patients as triple negative, and then what should we do?
That is a very difficult question, but there are some ways to overcome the protein degradation. Like, for example, if you put a piece of the tumor immediately under formol, instead of just leaving the piece entirely waiting without being processed, at least for that piece, you will have a better quality for the proteins, for the receptors. Okay, that's why, for example, the pathology or the immunohistochemistry done in biopsies is better than done in surgical specimens, because you put immediately the biopsy within the formol. And so you try to protect the proteins from degradation. So I would say that because of the delays in getting them to pathology and having them processed, if you can at least have a part of the tumor, like a biopsy, put in the formol, then you would have a better quality for receptors. In terms of the delay in getting the results, I'm afraid that has to be a priority of investment in resources, in human resources. It doesn't always have to be pathologists, but technicians, well-trained technicians, can process the material quite well and quickly, and they are, of course, less expensive than a trained pathologist. But if you don't invest, so we were discussing about best buys and health economics. If you do not invest in good pathology, then you may expend more in treatments that are not going to be efficacious. So imagine that instead of a triple negative, you have a ER positive disease. You can treat with endocrine therapy, which is much less expensive. Tamoxifen is much less expensive. And there are several genetics. Of course, you need to make sure that it's a high quality genetic, but it's much less expensive than to be treating with chemotherapy, plus the complications of chemotherapy, like Dr. Hannah Simmons explained. It's not just the chemotherapy, but it's also the side effects that then are expensive to treat.
To move into biology, do you think that this heterogeneity of triple negative patient will lead to new treatment approach in the next years?
That is our hope, right? That if we can subdivide the triple negative in small subtypes that have something positive, like there is one subtype with the androgen receptor positive, if we could prove that targeting that receptor that is positive, we could obtain a good efficacy in treating these subtypes, then of course that would be our dream. And I think that's where the science is moving, in trying to dissect and to reclassify the triple negative. However, I told you in the talk that this is not yet ready. We do not have high level of evidence on how to treat these different subtypes with specific treatments, okay? So for the moment, we have to treat all triple negative more or less the same way, with the exception in high income countries that you can use PD-L1.
And we are facing a lot of advanced stages in Africa. Wherever you go in West Africa, you will find very advanced stages of this disease. And is it a specific situation where we need to adapt to treatment? Or do you think that for the next few years, we will use more PD-L1 in neoadjuvant setup?
I think that in high-income countries, it is quite possible that we will move the checkpoint inhibitors, at least pembrolizumab, for the early setting. And we do not know if there is a relapse in these cases, if you should use it again or not. This is an unanswered question for the moment. However, I sincerely doubt that the majority of countries, even in middle income countries, will have the capacity to use all these drugs in the early setting. So I think that in some countries, we will still be using that in the metastatic setting. And these are, the problem of expensive drugs is not a problem solely in Africa or solely in low middle income countries. It's impossible for any health system to continue with these ever higher cost of medicines. It's just not feasible. And I think one of the things we can all do together is to fight for more reasonable prices of treatments.
It's also not just the cost of the medicine, it's the cost of the testing.
The cost
So,
of the testing,
Yeah,
indeed.
somebody's also mentioned on the group about genetic testing in Africa, but genetic testing and PD-1 testing in our situation is very challenging. The cost of the pathology tests, even if they're available in your country, is really quite limiting.
Should we move to some epidemiological issues? Because we have very different type of patients in Africa. For instance, in Senegal, it seems that we have much more triple negative patients. And do you think that genetic is the point, or we need to do more trials involving multi-center trials to assess the best use of products in Africa?
So I think that increasing the accessibility to trials in Africa is a good way of also having access to treatments. So it's one step. Now, to be able to have access to trials, there's also need to be organized and to have infrastructure. And that, of course, also needs some investment. But I think it is worthwhile, that investment. There are plenty of studies showing that when a hospital organizes itself for a clinical trial, overall, the quality of care improves for all patients, not just the ones who go into a trial. So we can use the clinical trial to improve the overall quality of care. And that is a good thing. But of course, we need to put some pressure on pharma companies also for them to invest more on clinical trials in Africa. And in terms of epidemiology, we have always seen, I'm very sorry that the presenter is not here to show us the epidemiology latest results, but we have always seen a higher percentage of triple negative in Africa. But I think that the latest studies where they collected the tumor samples and analyzed it faster and with high quality show that it's not so high as we initially thought. It is still higher than in other parts of the world. So 15% is what is in, for example, Europe or the US. I believe that probably in Africa it will be something like 20, at maximum 25%, but not more than that. And the initial studies would point to something like 50%. That is, I believe, not true and has to do with the quality of pathology.
I also just want to say there's a difference in triple negative depending on where you are in Africa. So I think West Africa seems to have a higher triple negative burden than East and South. I think East and South probably have about 20, somewhere between 15 and 20%. Yeah. So it is a unique challenge for our West African colleagues.
And what about the cytology techniques, immunocytology? Do you think that there is some development that would give us some good results in this field?
Well, I'm not a pathologist, but there's high controversy there is high controversy all over the world about the quality of immunohistochemistry based on cytology alone. However, it could be an initial, let's say, initial triage technique to use, right? You could have an initial diagnosis and perhaps analysis of ER as an initial result, like you were saying. Instead of waiting 2 months, perhaps you can have an idea faster on the ER and the diagnosis. But you always need the confirmation by histology because there are many false results with cytology alone.
And do you think that to fight against disparities between countries, early diagnosis is an issue? This year, if you do more effort in early diagnosis, we will have less disparities in treatment.
Yes, I'm sure Dr. Hannah Simmons will agree with me. There are many studies showing that treating advanced cancer is about 10 times more expensive than treating early cancer. So the less metastatic cancer you have, breast or any other cancer, the less you spend in treating the patient. So it's much less expensive to treat early disease. Now, I'm sure you know, and probably discussed in other sessions of aortic, there is a new WHO initiative on breast cancer, and it has 3 pillars. One is clearly early diagnosis. It's not really screening. Screening is not a priority. Screening is detecting something that is not visible or palpable. In Africa, the majority of cancers are visible or palpable. So what we want is early diagnosis, some prevention when it's possible, and then treatment, and then palliative care. All of those, let's say, and I forgot about the fast diagnosis, because there's a lot of delays. So there's a delay between the patient having the symptoms and going to the doctor, and then going to the doctor and having the diagnosis and starting the treatment. These are all cumulative delays that lead to the consequence of having to treat advanced disease. And so a lot has to be done in these different steps to shorten, to start treating faster in early, while it's still early, and save resources there. So I would also, if you allow me, just say that there are some projects that you can implement in different areas that are not very expensive and can lead to an earlier diagnosis. In the ABC Global Alliance website, you will see there is a repository of projects for hard to reach populations. For example, rural populations that are very isolated, low income populations. And there are several examples coming from some from Africa, some from Asia, some from Latin America, of not expensive projects that you can use and you can adapt. So please go there and watch, and you can just contact us and adapt the resources that are there to improve the awareness and knowledge leading to an earlier diagnosis. And sometimes the best buys are not really so expensive and start with a better awareness.
Thank you very much for this information, very relevant information, and I think that we'll take the best of it, all of us. Well, unfortunately for our speakers are missing. We have done our best to save this session, and I hope that it was very interesting for everyone. I would like to thank you very much. Hoping to see you in Senegal soon to talk about breast cancer, to talk about cost effectiveness, and to talk about advocacy. Because definitely, I think that advocacy is the most important issue of our conference. Till the time we won't take to the deciders that they need to help people to get equipment, they need to do more for training, they need to do more for availability and affordability of cancer drugs. We won't do any good research. I think that the issue is to be planned more. We need to plan more and more. And it's in planning cancer, fight against cancer, planning cancer control, comprehensive cancer control care, that we will have solution to African problems. So thank you very much, presenters, and I'm really sorry for all these speakers missing, and hoping that we'll see you again soon to talk more and more about cancer and our progress in cancer care.
Thank you. Thank you. Bye.
Au revoir.
Thank you very much to the breast cancer panel. I think they did a wonderful job considering some of the speakers weren't able to make it. They covered a very broad topic and it was a very interesting discussion at the end. Just to note that the session has ended early and so it will be lunchtime now and the next session will convene at 3:45. But in the meantime, there's something else that's going to take place before that comes about.
So for the next 10 to 15 minutes, we will be watching a video, which is a tribute to one of the founders of our TIC. It's actually two of the founders. That is Professor James Holland, who was a professor of neoplastic diseases and a medical oncologist at the Mount Sinai Hospital in New York, who most people who are in our TIC know that he was not always alone. He was always accompanied by his wife, Dr. Professor Jimmy Holland, who was a psycho-oncologist and had a special interest in the psychology of the patients who are diagnosed with cancer. So can we have a look at the video, please?